Now, we use the term DBS, which is the deep brain stimulations. But it doesn't mean it has to be stimulation. People thinking that, okay, deep brain stimulation, okay, I'm going to be stimulated, right? Excited, stimulated. It's not in that sense, because as I mentioned earlier, the circuitry in the brain, the neuronal working, sometimes some neuron is inhibitory. So if we stimulate that neuron, actually it's not stimulate, it's stimulate neuron that inhibit the next neuron. So then don't think in the sense that deep brain stimulation, it has to be stimulated. It just stimulates the neuron that, just think in this way is better. Modulations. It's like a neural modulation. Okay. And it depends on where we put it, then it creates a different signal and different symptoms control. Now, going back a little again, originally when I'm talking about neural circuitry. So the ancient time, we don't have a medicine, we don't have levodopa, we don't have even trihexyphenidyl, we don't even have benztropine, nothing. And then they use the surgery to treat the symptoms by put the do the surgery, put in the, not the DBS, but electrode, or I can say leads that make a little burning, like a thermal, just basically electrical cauterization type kind of thing, make a little holes in that area that we want to do to block to modulate this abnormal transmission and help it. But then later on, we have more medicines, then the surgery kind of, okay, now why we do the surgery, why we take medicines, right? And then after that, we learned that when we're taking carbidopa, levodopa in particular, it creates a problem later on, right? Because it's work, it's always work, but it costs up and down. You get better, and then you peak at an hour, and then some people may have dyskinesia. Everyone know, we don't have to show video. I think everyone know the dyskinesia look like, and then the wearing off, and this thing keep going on and on and on. At first, maybe you feel like, okay, you can take every 4 hours levodopa, but now we have to take every 3.5 hours, and now we have to take every 2 hours. I just saw another patient yesterday. He said, "Oh, for me, I have to take one every 1.5 hours." Okay, so because it's going like that, we call motor fluctuations. Okay, and when it's peak, it causes dyskinesia. So too much, too little, too much, too little, and what's that? Can't you regulate that somehow? Yeah, that's what we're talking about here. Yeah, so the treatment is that by trying to adjust the medication first, right? Obviously, right? We don't just go to, okay, you go with surgery, right? We have to moderate the medication like levodopa. At first, maybe it's easy, just by using the small amount of levodopa, but more even it out more often, but small. Instead of, let's say, instead of take 2.5 tab every 3 hours or every 3.5 hours, then you use the 2 tab every 2 hours. So those kind of modulation, or use a medicine to reduce the dyskinesia, or use other medicine that is not carbidopa, levodopa, to try to help smooth it out. There's a medicine to extend the duration of action of levodopa. There's a medicine called dopamine agonist, like a Neupro patch and Mirapex, Requip. Those are the things that have a longer half-life, so it can help it out, so it make it stretch through. Or the medicine like amantadine to help with reduce the dyskinesia. And then when we try all of this and it doesn't work, that's when surgery comes. Okay, and along that time, the surgical technique getting better too. Okay, but no one like it yet, right? Because we had such a good result from medication. But then we realized that, okay, medication also had a problem. At the same time, surgical options getting better, technology is getting better, safer. And then DBS coming back, DBS start. Okay, so DBS, as I mentioned earlier, deep brain stimulation, DBS. Okay, so and then the scientist said, okay, why we have to burn the brain, right? Or zap the brain, make a holes in the brain. We can use the electronic device that deliver electricity, and we can control it to moderate this circuitry that we talked about that is not normal because of the lack of dopamine and make it not normal. And then that's the how the DBS start. And the DBS has a few location of the brain that we can use the DBS for Parkinson's. It depends on the main symptoms that you have. Some people, main problem is tremor. That's another option. Some people, all other Parkinson's symptoms doing pretty well, except tremor. Even when we try to adjust medication, give something, tremor is still bothering and it's not getting better, but everything is good except the tremor. That is also another reason for the surgical option. Okay, so there are two reasons for the surgical option. One, up and down, motor fluctuation and dyskinesia, and two, intractable tremor. Means that we try all these medications and still bad tremor. So those are two indications. And so let's say someone has the tremor as the main thing. Everything else is good. Sometimes we can even just do the DBS in what we call thalamus. Okay. Have you heard of the term thalamus before? Yeah, it's just part of the brain in that like a little tight knit area in the center of the brain. That's a thalamus, basal ganglia, and kind of work together. And but the thalamus one, it will help mainly only the tremor. Other symptoms of Parkinson like stiffness, slowness, walking problem, sometimes can help a little bit, but sometimes not. Okay, but if someone who has a motor fluctuations up and down, usually the first option, the most common option that we use is DBS to put in the subthalamic nucleus. Okay, it's called STN. Okay, and again, this is just part of the basal ganglia too. Okay, and then another option is globus pallidus interna, GPI. GPI, globus pallidus interna. It's again, it's still in the same region. It's just like next to each other, but it depends on where we want to target. And there's a good thing about the DBS that we can decide on which one we want to target. And for the globus pallidus interna, we don't use that often, but sometimes we use it in people whose main problem is dyskinesia, because stimulation in this region can get rid of the dyskinesia. Okay, but in the subthalamic nucleus, the stimulation itself doesn't reduce the dyskinesia, but dyskinesia will reduce or stop because we can reduce dopamine a lot. Because as you know, that carbidopa levodopa is the main reason for the dyskinesia. Okay, so if we use the DBS, then we can drop all medicines a lot, then dyskinesia go away. Okay, and that's another difference between the subthalamic nucleus and globus pallidus as well, because in people who has the surgery put the electrode in the globus pallidus, sometimes we cannot reduce the amount of dopamine medication that much, maybe a little bit, not like drastic. But people who has a subthalamic nucleus, we can reduce it a lot. Like some people can even take only half a tab 3 times a day, 1 tab 3 times a day, or 1 tab as needed, so on and so forth. Okay, but there's always pros and cons, because people who has the who is older, and when I said older, there's no real age cut point. It's more about cognitive age. Okay, because some people 65 may be cognitively impaired. Those are the people who that not a good candidate for the DBS, because when we do the surgery, the electrode go through the part of the brain like called frontal lobe and go down to the basal ganglia, and just by putting electrode in, sometimes it can cause more problem with the brain thinking, executive function, talking, and things like that. That's why we always don't want to wait too long, because you had a window opportunity for the DBS. And if it's like a younger than 75, usually it's okay, you know, but if it's older than 75, we have to kind of think harder. And, you know, it's possible that people with older than 75 can have a DBS too, if they cognitively intact and like active and everything. So usually we refer our patient to a neuropsychologist first to evaluate and see if they are cognitively intact and good enough to go with the DBS. Because if not, then we back off. And that's come to the GPI Dbs. Remember that I talked about the GPI, globus pallidus interna? Those targets tend to cause less of the problem with the cognitive problem. So sometimes we can use that in the older populations. But all this depends on individual situation. So when I need my patient to get the DBS, I usually refer them to either Duke University or UNC Chapel Hill. They have multidisciplinary approach. They have a neurologist, is in my counterpart over there. They have the neurosurgeon and a neuropsychologist, and they work together and evaluate you and to make sure that you're a good candidate before we go ahead with that. So now nowadays there are so many DBS at 3 companies now. For such a long time, like decades, we have just only Medtronic company who make this DBS system. Now we have Abbott and we have Boston Scientific, and it's a good thing because they compete each other to figure out a good one for us, right? But then the thing is that it's like a computer and software, right? It's all updated, and they say, okay, now I think this one is good one. Okay, next when they have some new features, okay, maybe this one is good one, and they keep changing. So and what make them different? Okay, so the let me start with the history again. The Medtronic, we've been using it for a long time. The electrode, okay, is gonna go to the brain, right, and then they kind of wire underneath the skin and go to the pacemaker. It looks like a pacemaker for the heart pacemaker. And before we had to put one side and then connect to each pacemaker. We have 2 pacemaker, but now we have just one, like routed together to just one. Okay, and then the electrode itself is getting better too, because before at the tip of electrode there are four contact that we can use. Okay, 4 contact that we can use. And why we have 4 contacts to use? Because when the surgeon put it in, how we know which one, if you're gonna so we have options, right, where you want to stimulate, where you want to do some modulation, because we don't know exactly where it's going to be. You know the subthalamic nucleus, what size? What you want to guess? The size of thalamic nucleus at the, it's kind of round. It's not round. It's like look like this, like a rugby balls. But you think that how wide, or you think it is? Like a peanut. Yeah, like 6 millimeter. 6 millimeter. Very little. But the electrode is very small too, and it can fit in. So let's say this is the blown up subthalamic nucleus, and it's going in like that. Okay, and that's why at the tip, at the bottom, then we have 4 options, because we don't know if the surgeon put it exactly like that, or like that, or like this. We don't know, right? So at least we have 4 options to use. And when we talk about the subthalamic nucleus at this small, and it's not like it stimulates anywhere is the same thing. We want the one that go to a little bit more to the on the side, on the top region, like around. Let's say if it look like this and it's like around here, that's a perfect, because different part of subthalamic nucleus also do different thing. So that's why by having the 4 contacts at the tip, then we can test which one is good for you or which one not good. Okay, and the same thing with the globus pallidus and thalamus too. That we have for the tip, because we use the same leads, electrode. We just depends on where we want to put in, but we have the options. So now, what is the newer development over the past few years is that when you think about this, let's say we put the electrode in, right, in the region that we want to stimulate, and we start with we use the term amplitude. That stimulation is a square wave stimulation. So we shoop, 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 like that. Okay, then we said, okay, this is not good enough. We need a higher intensity, higher voltage, higher amplitude. You know, we like want it more punchy. We have to increase it. But when we increase the intensity of the stimulation, it makes the size of the stimulation bigger too. It's not just increase and then stay the same place. It's bigger and bigger and bigger and bigger. It's like a hurricane. You know, when it's very, very hurricane, it can involve 2 states, like a Florence. Remember Florence? It's sitting there and cover both South Carolina and North Carolina at the same time, right? But if you compare to a tornado, it just maybe next house don't get anything, but this house got something, right? That is the what I want to compare. So so the problem with the DBS is that if we need higher intensity, it gets bigger, and when it's bigger, it's too big and it's spread to the other area that we don't want to stimulate. Okay, so let's think about this. Let's say that this part is the brain that we want to stimulate, right, to get a good result. But then next to it, maybe there's a nerve fiber, the fiber tract or nucleus that control your speech or your balance and your eyes. And if the stimulation big is get out of the location we want to target to the next door, if it's involved the fiber that control the muscle movement, it can cause a tightness and like pulling the face or something like that, or double visions or speech problem or balance problem. So how are we gonna fix it, right? In the older electrode, we have some way of manipulations a little bit, but not very much. But newer version over the past few years, couple of years, is that now when we stimulate, we don't have to stimulate the whole ring anymore, because remember that the DBS leads like this, right? When we stimulate, it's gonna go like this, right? Like circumferential, bigger and bigger, right? With electrode in the middle, and then kind of bigger and bigger and bigger. But now electrode now from the company, actually now all the Medtronic, Abbott, and Boston Scientific have the middle two of the the contact out of the four, that the middle two, we have ability to select, like, okay, just this side, or this side. Okay, so it's mean we don't have to stimulate the whole thing. If the whole thing, let's say we don't want to, this part of the fiber causing a problem with the pulling, tension, speech problem, and if you go bigger, it involve this fiber, and we don't want that, we can deactivate this side of the contact and just keep growing this way, then it will not cause a problem. So basically we can shape the stimulation so that it not go to anywhere, right? But and then now another advancement over the past year is that before we don't even know where we stimulate, right? Because you went to hospital, surgeon, MRI, doing mapping and everything, and put electrode in, come to the doctors like me and doing stimulation, and I have no idea where those contact is, where. I have to test it out and try and error. I said, oh, okay, let's try this contact. Oh, okay, your face pulling. Okay, let's change it to the different contact, right? And then I do also this. But now, over the past year, excitement to me is that now we can even merge your MRI from the surgery, okay, into the software that I have a programmer, a programmer that I use for adjustment of the DBS. We can merge it in my programmer. Then they have the animation to show that, okay, where the electrode and where is your anatomy, your own anatomy, not just like cartoon anatomy. It's adopt from your own scan. And then they use the MRI, they use the CT and the software, and then now you can see where's the electrode and the location of the subthalamic nucleus, or the location of the thalamus, and the location of globus pallidus, where it is. And then instead of trying to, okay, I'm gonna test it out. Okay, tell me what. Okay, you have a problem. Okay, let's move on, and write it down or something like that. Now I can see, and then I can say, okay, instead of just first look at you, I can start looking at the location first, and I try to make the location stimulation, because it's going to show when I do it, it's going to show how the stimulation locations or the region, it's going to show the shape of the stimulation in it. And I can see, oh, I want to fit in this part of the brain, like at the top, the right, and a little bit above, go back a little bit or something like that. And then I got a good location, right? And then now I start to stimulate and looking at you and see how you do, and then adjust it further. So that's good. And Medtronic also have a different way of doing to help us to make it the good stimulation adjustment, is by that we now can even hear, or not here, but we can collect the wave form, the activities, your brain activities in a waveform looking in the programmer. So and then I don't want to give you too detailed, but by looking at the type of activities of of your brain signal, we can decide whether this is a good target, not good target, or what we should increase or decrease, not just by the examination only. Because before, we just use examination as main one to make decision of where you want to do, or how much and how little we have to change. But now we have the tools that we can look at the anatomy of you, not just a regular anatomy from someone like autopsy, like a long time ago that they make it for ancient time. It's just for you, like tailor. So those are the very good advancement to help us, to help you better, because we can make a different shape, the form, stimulations to get a good result. Now, this is about the DBS, right? But then the surgeon, remember that back in ancient time when the surgeon put it using electricity to burn your brain, but along that time, the surgeon also try to find a different way. Instead of just doing like the old time, they used gamma knife, which is a radiation. They use laser, and now they use the ultrasounds. Okay, you may hear from this focused ultrasounds. And everyone here heard about this? Okay, but one thing that I kind of upset me is that when they advertise it in any commercial in a hospital or a center, they said non-invasive or ultrasound for the liver or kidney or carotid Doppler type. That, oh, that's great, I want it. But actually it's not really true. It's just that it's not invasive to the skull, but it still make a holes in your brain. I don't know, can we call the non-invasive or not, or incisionless? So it's not incision at the skull, but incision in the brain, basically. But it's still a very good technique nowadays, okay? Because now they use the ultrasounds and they use the MRI to help with the targeting. And so you're going to be in the MRI suite, with the big holes and, like a tunnel, and you have a little big hat, like very like dome shape for ultrasound to beam into the location. And the same thing, they just use the same location. We talk about thalamus, subthalamic nucleus, the GPI, globus pallidus. But instead of electrode for stimulation modulations, they use the ultrasound to beam to that structure and make a little small hole, like it's a little tiny one, okay, to help with the treatment. The first one come out that been using now for a while, a few years now, is the target is thalamus, and actually start out with the essential tremor first, not the Parkinson's. The essential tremor is? Essential tremor called ET, okay? That's what it stands for. The essential tremor is the condition where we have a tremor, but the difference between the Parkinson tremor and essential tremor is that essential tremor, you have the tremor when you're action, like doing something, like hold something, eat something, okay? And when you're writing, you can like that. That is essential tremor. But Parkinson tremor is more like at rest. Like when you're sitting, do nothing, your hands on your laps, and you kind of like this. And when you lift up your hands, the tremor go away. Those are the resting tremor. So the resting tremor is a classic tremor for Parkinson, but action tremor is classic for essential tremor. But as usual, everything is in a gray zone. Sometimes people with the Parkinson can also have action tremor too. And sometimes when you talk about a resting tremor, it depends on what you mean by resting, right? Because if you lift, let's say your hands are resting on your laps and watching TV and then shaking like that, and you lift up, it's go away. But if you hold it long enough, not have to be super long, right? Not like an hour. But at first, the tremor stops. But once you become at resting state, they're coming back. It's still resting tremor. Okay. Or when you're walking and your arms hanging beside you and it's shaking when you're walking, it's still resting tremor. Okay. But when you do like this, there's no tremor. But when you get closer, like eating and then hold it there and then tremor coming back, it may be just another resting tremor too. So this is kind of mixed picture. But anyhow, the essential tremor usually they don't have resting tremor until we become more advanced. Sometimes they have some symptoms that look like Parkinson later on. So the focused ultrasounds thalamotomy means that they make a little holes, a small hole in the brain, in thalamus. It can stop the tremor very well. Okay, so how are we gonna know who need this? So first, again, with the medication first, and we fail. And if you fail, then the tremor is very bad, and you need something, but you're too old to get a DBS, then the focused ultrasound of the lamotomy would be a one. Or some people don't like the idea, have a surgery, have a holes in the put on electrode and things like that. Then they can use this technique. When it first came out, we can do just one side. So if you do the left side of the brain, it control the right hand tremor. The right side of the brain control the left hand tremor. But now the FDA already approved to get two sides, but usually we don't do two sides all at once. We do one side and maybe wait for 6 months or so and do another one. And then now they I think the FDA also approved for globus pallidus lesion, but that one just only one side. I just talked to a neurosurgeon at UNC just another day on the email, and he said that FDA is okay for the GPI, but for the subthalamic nucleus, it's very small. Remember we said 6 millimeter is very small. I looked it up on the article. The most recent one I read, it showed that it's not a good way to go because it's too small. And actually, when we make a lesion, when you use the term lesion, mean like a little hole in the subthalamic, some people can cause dyskinesia because actually people without Parkinson or anything, when they have a stroke that attack this region of the brain called subthalamic nucleus, it can cause, we call balismus, hemibalismus. Okay, and so when we do the lesioning with the ultrasounds or gamma knife or whatever in this lesion, it can cause the same problem, and then we cannot treat it because it's already happened, and it can be sustained, but it can get better as well. So I think right now for the focused ultrasounds therapy, the tremor is the main one. The GPI, because it's approved for just one side, I think can still be a problem, because then what we're gonna do, we have Parkinson on both sides, right? And if we had a surgery on one side, but one side is medications and we adjust it, and the side that have the surgery don't need much of the medicines, but the side that need the surgery don't have a surgery, need more medicines, then we get into trouble. Like, okay, left leg working good, but right leg not. And then if I increase the dose too high, then we have dyskinesia again. So it's difficult. I think for Parkinson, we need something that we can do both sides, so that we have to modulate on both sides. And for the tremor, it's easier, right? Because we can just target on just the tremor only. But this is kind of focused ultrasounds that we're talking about. Usually I refer a patient to Novant Health, Charlotte. And his name is Dr. Charles Munyon. And he told me that he's been doing these focused ultrasounds for the tremor, not GPI, not for the globus pallidus, for a while for the essential tremor. And he's told me that he had very good result from that. But in my own personal experience, it's very limited. I have only 2 patients had that for the essential tremor, though, not for the Parkinson's. One bad, don't like it, and I think he got it the first one in the VA, and he didn't get a good result. And then I refer to another place to get another one, still don't get a good result, and had a lot of side effects, like that problem with speaking, balance, and everything. And then another patient, which is number 1, number 2, great, perfect. So that's why I don't really can say it from my personal experience yet. The times will tell, but usually we can always explore. And I can refer you and talking about it, and can plan it together, and depends on how you feel. So those are the surgical options we currently have. Okay, but I want to tell you about the future too. Yes.
Before you get to the future, I wanted to ask you, if you could, what is the success rate for DBRs? Of course, symptoms are different, right? So how do you judge whether or not DBR?
You mean DBS, right? Okay, so this is about the selection of the patients. That's the number one. If you select the right person, always great. But if something like in the gray zone, things can happen. Okay, so when I say selection is the most important thing, is number one, younger is better. Okay, but again, there's no cut point, but younger is better. So usually when I have a patient who have the motor fluctuation, dyskinesia, or tremor that not in good control, I don't wait until they're 80 to talk about DBS. I start talking to them. After I feel like, okay, I had a feeling that I'm going to run out of the options, I start to kind of talk about this option behind, just like in the background information, so that they can prepare. And then once we really fail the medical treatment, then it's easier, right? Not just like wait until the end and talk. So usually if let's say the levodopa, at first you take 3 times a day, forget the dose, nothing happened. Then later on, a year, 2 years, 3 years, then you say, okay, I have to take it exactly every 4 hours, and now I get it exactly every 3 hours. And when usually, this is my personal way of doing it. The different doctor may have a different thing, but the 3 hours is my kind of starting point. That okay, it's the 3 hours. I'm gonna start talking about the DBS or surgery, and because if you have to take medicine every 2.5 hours, it's not no life, right? And it's always overshoot and undershoot. It's never like smooth. So if someone has a problem, I start to see that. I start talking, and then once it's below 3 hours, then I refer to Duke or UNC. Hello, how are you doing? And have a Duke or UNC to start to talk, because it's not fast anyway. So if I refer my patients to Duke or UNC for DBS, it can take 3 months or 4 months to see a doctor and plan, and it can take time. So, and then it's a good idea for everyone to get some information and feel comfortable with the team before make a final decisions. So back to your original point of question, how we know who is a good candidate. Number one, younger, motor fluctuation that is seem to be not going to be in good control, and then cognitively intact, good cognitive intact, and no severe psychiatric disorders like a hallucination or something like that, or severe anxiety or something. Because you know, when you have the DBS surgery, you have to stay still in a frame, and for a while. I don't depends on the surgical center. Some can be few hours, some people can be longer hours, and you're gonna stay there and you get anxiety, and then you want to get out of the OR. You cannot go there, right? So basically, younger, cognitively intact, psychiatrically okay. Okay, maybe a little anxiety, a little depression, that's fine, but nothing bad, and definitely no hallucinations. And but if someone had a hallucination because of side effect from medication for Parkinson's, and we get rid of it, change something, and then the hallucination go, and then they can become a good candidate again. Okay, so and if we choose the right person, it's always perfect. And unless, you know, like 1 to 2% depends on the center, may cause a bleeding, cause a seizures, or something else that's not related to Parkinson, then that's a good thing to go to the center that has been doing for a long time, and always asking the surgical surgeon and say that what is their statistic, not talking about the global statistic, but in your hands, how many patients do you do this kind of surgery, success rate, any adverse events happening, and what kind of adverse event, like bleeding, infection, or something like that, then you can decide. But for the DBS, if you look at just Parkinson only, not about surgical risk, things like that, if we choose the right person, it's always good. It's always good. But if you're getting older, then even though the memory testing can look okay, but you may be at the edge, and by just a little bit, you can get confused. I have one patient that neuropsychological testing looked good, okay to get the DBS, but then after the DBS, she's get very confused. So that's why I have to be careful, and that's why younger is better, you know, because when you're younger, your brain plasticity, adaptation, things like that is better. Now, I want to talk about two more things. Okay, one is the future and one is the current. It's not exactly surgery, but maybe I should talk it today because it kind of linked to it. Have you heard of duodopa? Okay, yeah. So this is still medical treatment, but using the it's like a tube feeding type, in the stomach. Go to the small tube feeding to the stomach, but not stay in the stomach, but kind of go down further to what we call jejunum. You know the jejunum, like a stomach, duodenum, jejunum, ileus, and then colon. We don't have the picture, but we have to just show like that. so so we put the two things, like people who had a tube feeding go to the on your stomach and go down, and then the end is at the jejunum, and hook it up with the pump. Okay, about this size. Okay, and there's a gel cartridge attached to the pump, and it's a levodopa gel. Okay, and we can program it and say that, okay, first dose in the morning, we push the morning dose. It will come out as a bolus because we don't have anything for the overnight time. So we push the bolus amount, like maybe 10 cc, 13 cc, depends on the individual. Then after that, it will become like continuous. And it can be 1 cc per hour, 1.5 cc per hour, depends on the individual. And then we have ability to push the extra dose. There's a push extra dose button. Let's say we want a rescue, like a kind of typical sometime even when you take a levodopa and you need a real quick rescue, you take a small pills of levodopa and chew it and make it kick in faster. Something similar to that, but you can push on the pump itself. There's extra dose button, and but we can cap it. So okay, you cannot keep pushing it every hour, something like that. I can put in the interval that, okay, I allow you to push it every 2 hours. So if you click extra dose here and you want to click again, but it's not 2 hours yet, then it will not deliver until it's 2 hours. Then you get it again. So those the levodopa pump. Okay, so this is a way to try to make it smooth, because by pills you cannot make it smooth, but this way it make it more like infusion pump. Okay, a little bit, but sometimes we need this. Okay, but I have only maybe 6 patients, something like that, because it can be inconvenience for you because you have to carry the pump, and they have the way that you can carry it with a bag, or now they had a vest and they had a little pocket on the side of the vest and carry it, so it's make it easy or more simple. But then you have holes with the tube feeding. You have to clean it and not look nice, then have the wire, something like that inside, not wire, but the tube itself. But you can still go swim or doing things as long as you disconnect the pump, because this pump is most of the time we use it only the daytime. When you go to bed, you disconnect the pump and then you go to bed, and in the morning you get the pump and with a new cartridge and put back on for the daytime. But some people need it overnight as well, because still have the up and down at nighttime. Extend release is not good enough. Yes. Yeah, so those are good candidates. And again, this is coming from me. Okay, it's not the guideline from any organization, just me. Whoever need a DBS but cannot have a DBS, then will be duopa. Because let's say it's like too old, contraindication, don't want the DBS, this will be the way. Okay, but some people said, I just saw another gentleman yesterday. He said that he's taking carbidopa, levodopa. I forgot exactly, but let's say 2 taps every just 6 times a day, like 3 or 4 hours apart. But he said it takes about 15-30 minutes for medicines to kick in, and it lasts for about 1.5 or 2 hours. I said, okay, you have a lot of gaps there, because if you take just only 4 or 6 times, but it lasts only 1 or 2 hours, and then it takes 30 minutes to kick in, it means you have a lot of gaps. And I asked him, and he's very young too. That's the thing. I said, you're perfect candidate for the DBS. If you were my family, I'm gonna say that go for the DBS. He said, no, I don't want it. and I don't want duopa. I don't want anything. I'm good. I'm just play around with it. It depends on my activities. I can do my own thing. I am comfortable. I say, okay, that's fine. And just if you change your mind, let me know. So this is nothing like a must, because the Parkinson is not like seizures or brain tumor that, okay, you have no choice. You have to do this, otherwise you die. This is more like convenience and lifestyle. So different lifestyle need different thing, right? So so the duopa is the one that use the gel form of levodopa and make it more smooth. Okay, and in next year, I was told that next year we may have a different kind of pump become available. Okay, so instead of deliver levodopa through the jejunum small bowel, now there's a new form. It's subcutaneous pump. Will be like similar to insulin pump. Okay, so insulin so you don't need the tube feeding put in, so that's a good thing. But then not a good thing is that then you have to stick your stomach, put the small needles, subcutaneous needle, to hook it up with the tube, smaller tube, and then go to the pump. So it's going to be a different kind of pump. I don't know what it's going to look like yet because it's not here yet, but it will be a pump. But I was told it's going to be smaller and less heavy compared to the duopa pump. And this levodopa going to be delivered directly to the subcutaneous tissue. So it means that they bypass the GI tract. It go directly to the bloodstream, which is a good thing too, because you know why? Because as you can see for yourself too, or you can hear from your friends and family, that levodopa, sometimes when you take it, it may not work, sometimes not work, and sometimes take longer time to work because the absorption problem, right? So because in Parkinson's, it's very complex. It's not something simple anymore. The more we learn, we don't know a lot about it. And so the absorptions of the levodopa can be affected in a more advanced case for different reasons, including the movement of the bowel itself. Let's think about this. Take the pills, right? It go to your mouth, go to esophagus, and then go to the stomach, and then it has to go to the small bowel to be absorbed, because the absorption is at duodenum, jejunum region. And some people, the levodopa you take, it may just stay there in the stomach and go nowhere. And how are you going to get any result from that? Or maybe delay to go there, right? And then we talk about the good germ, like probiotics, those type of things too, that help with the absorptions, help with the Parkinson overall. That's a different topic. I don't want to go into detail, but so basically in more advanced Parkinson's disease, the absorptions of levodopa can be affected. And so with the duopa, it's better in one level because it delivers directly to the duodenum or jejunum, and that's why they call the duopa at the first place, because duodenum, but now they put it the tube at the jejunum level, but it's going to be next to each other anyway, around that area. So by doing duopa, the levodopa will be delivered directly to the place to be absorbed, and a smaller amount. Okay, and by doing small amount is a good thing, because then if it's not up and down. And then second thing is that if you eat something, then like with the protein, it can affect the absorptions of the levodopa. And if you take a pills and then close to the meals, then affect the whole pills, right? But if they deliver 1 cc per hour or 1.5 cc per hour, if you eat something, it just affect at that 1.5 cc. But there's you still another hour you have other, right? So it's less. So it's not the whole thing. So it's affecting less. And if we have the subcutaneous pump next year, even better, because then we don't need to worry about the food, because it goes directly to subcutaneous. But I was told that we have to change the needles that connect to the pump 2 times a week or something like that. I'm not so sure exactly because it's not here, but I'm excited about that too. But in general though, if someone who needs something like this, I prefer DBS because it's less maintenance. Okay.
Do they have a chewable pill?
Yeah, but you can chew it. You can just chew the your typical carbidopa, levodopa yellow pills, but there's the dissolvable one called Parcopa. So it's dissolvable. So when it's dissolvable, it's good for two things. One, some people have difficulty swallowing, and two, it kicks faster. But if you can just chew your regular yellow pills, it's easy and cheap. And now they have a different tablet coming out called DV. I think it's coming from dividing. I think I'm just guessing. So basically, it's like four pieces, because some people they take one tab is too much, half tab is too little, then we want to do 3/4. It's difficult to break it, right? But this one, they design it so that you can break it at 1/4. But it's expensive and it may not cover. It's not, all this thing is always a problem. When it's something new coming out, I'm excited about it. I want to use it. I said, but okay, now insurance doesn't cover. And they cover, like commercial is covered better. But people with Parkinson is more with Medicare. Yes.
You just mentioned Medicare. What, are these procedures covered by Medicare?
Yes. Yes. I never hear anyone that got denied by it. But it's not like, okay, you just got the first diagnosis Parkinson and go for the surgery, then not they're gonna cover for that. They have like you have to do a certain time of how many years you've been having Parkinson's. Is that you try all these medicines and fail, documenting it. Then you'll be eligible. And another thing that I want to tell you, I forgot to mention, is that before we go for the DBS, okay, we usually, when I say we, I don't do it now because I usually let the team at Duke or UNC do it for me. They do it anyway. They will see you when you're off, completely off, like no medicines overnight, or even I think one may be more strict than another, but at least 8 or 10 hours, like no medicines. Okay, so then they do examination, like when you see us, we have you do this, do that, and walking, and we had a scoring system. Okay, and then they will give you medicines, but a little bit more than your typical dose, just to maximize it. Okay, they had a way to calculate it, and then they do examination again an hour later, and then they compare the score, and then they say, oh, okay, if there's good score improvement, then it means that you're a good candidate. And the reason for doing that is that DBS is not really, or surgery of any kind, is not really better than the levodopa, except for the tremor. Tremor is a separate thing. The levodopa is kind of 50% chance of getting improvement of the tremor. But other symptoms of Parkinson, everything else, DBS or surgery is not better than levodopa at the peak. It just makes it smooth without up and down. Okay, so they want to know that, okay, at the peak of the levodopa effects, how good you are, and that's what you get. But most are like less up and down. Okay, so that is the I will have I think it's now I still have some more few more minutes. So that is the one that we have available. Okay, except the subcutaneous one maybe next year. Now I want to talk about like the future. The future. There's been work for a long time, many decades, on the gene therapy, okay, and the technique on how to deliver the gene to the brain to treat Parkinson's, okay. But first, I want to tell you first, when you talk about gene therapy, we're not talking about change the human to a fly or something like that. There's so many detail in it, okay? The gene therapy just means that we modulate a gene to do something that we want, okay? And it can be many things. One, the easiest thing to do that is not a cure yet, just symptoms control, is that they try to deliver the gene to the basal ganglia area again, or in the brain, to create a moderation because of remember we talked about DBS, that the stimulation in that certain part of the brain control different things. The medications is a chemical to control the modulations in the brain. So now they can deliver the gene that produce things. For example, the chemical substance or enzyme that enhance the production of dopamine, for example, or or the enzyme that have a similar effects like a DBS, but instead of using electricity, using the gene to modulate it. But in a newer, like and sometimes they use what we call neural what's it called it's a hormone in the brain. Which is a neuroprotective or neuromodulations to help nurturing the brain. Those kind of genes that they can deliver to the brain, and it's still under investigation, not to the level that we can use. And in order to deliver that gene, they use virus. The virus had we can insert the gene we want into the virus and then inject the virus into the brain, and then the gene in the virus coming out and then doing something to help with the brain. So those are the things that they can do. But they have to choose the virus that's not harmful. And it's kind of blank, like use the virus to be a blank envelope to deliver something to the brain. Okay. Now ultimately, hopefully in the future, if we know the cause of the Parkinson's, the gene like mutation, then maybe we can use the same way of delivering system, but now this time not just deliver the gene that treat symptomatically, but really do something to change something. And still many more to come, and it show many promise that eventually we will do something better than just treat the symptoms. And that's about it. So anything that we have, any question, we're open for discussion. I don't know. I don't think it's 5 years. I think it have to be longer than 5 years. I don't know. Longer. I don't know. But we never know. Sometimes we can have a breakthrough, something, and it changed the whole world. I don't know. We just hope that happening. But it's not something that, oh, okay, like a subcutaneous pump. I say, okay, next year it's gonna be it's gonna be coming out, or the focused ultrasound telemetry, or the GPI telemetry. There's still some work to go, and with the clinical trial, and maybe not that kind of thing. So it's more like concept, like a concept car, but we don't know when it's gonna come out.
Is there a way to tell how an individual obtained the Parkinson's due to Agent Orange with these heavy metals?
Yeah. So there's so many things. It's the interplay between your gene and the toxin or poisoning or whatever in our environment. There's a lot of things. For example, let's say some people will stay in certain location that have the like Agent Orange, like in that area that have the Agent Orange. But why some has the Parkinson, but some not, right? So it's an interplay between the gene, and that is another hope for the future, that we had a precision medicines, because different people with Parkinson have different gene and maybe different thing. We just lump it together as Parkinson's, but actually maybe different kind, and maybe different kind need different thing, and the different type of the Parkinson subtypes may progress faster than another. Some subtype may be more with cognitive problem, not such a motor problem. Some subtype may be more tremor. Some subtype may be more with the walking stiffness. And then some maybe not the subtype, but the same subtype, but different gene in you can respond to the medicine or treatment differently. Maybe you good with this one, but you get another one. That will be a future we're looking for. Precision medicine.
No way of telling just yet.
No, I don't even know. But I think working more and more, and then I think in the future, because all this thing is not just one group of doctor doing it, right? It's a lot of scientists and work on the different type of thing. The gene, people who work on a gene, people work with environment, toxin, people working with the robotics and high-tech AI, some people working on medical medication, and hopefully all of this coming, we will find something.
Who would you recommend I see? My two sisters are also diagnosed with Parkinson's. I'd like to get a workup.
I think you can go anywhere that have a movement disorder specialist. That's the key. If let's say I'm not talking about just here, okay, then like everywhere. So so if that location that easy for the access to the hospital or a clinic has movement disorders specialist, then go to the movement disorder specialist. But if there's a place where there's no movement disorder specialist at all, then go to the neurologist.
What do you think about the Kenobi and
Yeah, this is not for this talk, but that's one of the things that's a rescue. Is it is the way to make things quick, faster. Yeah, so it's an apomorphine. It's the dopamine agonist. It's dopamine agonist means that it's the medicine that is not a real dopamine, but it works on receptor of dopamine. And apomorphine is one of the options. Requip, Neupro, Mirapex, those things also dopamine agonist. And but the special thing about the apomorphine or apoquin, this one is named apoquin sublingual, is that is quick action within about 15 minutes, and you will see the effects. And but it lasts for only an hour or 60 or 90 minutes. So basically, it is just a rescue. It's not when people have the up and down and have to wait for a long time for the levodopa to kick in. We can use something like this, or just chew the levodopa. And they actually even have inhaled levodopa. Yeah, but that is not for the long term. Not long term. I'm talking about not like to smooth out the whole day. It's more like rescue. Yeah. Okay.
You tell the difference between somebody that has Parkinson's and somebody that has Parkinson's with Lewy body.
That is more like history. Which one first? Physical function problem first or cognitive function first? If the cognitive function first, then it's the Lewy body. So, but we have no, or people who is very sensitive to levodopa, even small dose and already cause hallucination, paranoia, delusional, there's more Lewy body, or cognitively much worse than a physical function problem. That's a Lewy body. But there's no blood test and scan. Actually, there's a scan that we can use to separate between the two, but insurance is not going to cover for it. It's called PET scan, FDG PET scan. People with the diffuse Lewy body have the hypometabolisms in the back of the brain, but it's not like exact. But the treatment is still the same. Let's focus on the surgical option. Okay, this is for today's topic. Okay, anything else? Okay, let's see. I think we are good on time. Yes, and I don't, because today this is a rescue mission too myself. I have a class that I have to attend at 11, so I will not be able to stay for the support group. And you think that you want to try to do it your own, because usually the what we want for the support group is that even we are here, we don't want to create a Q&A things. We want to make like to have a group discussion, sharing your thought. For example, someone has some problem with something, and then share it with the rest of the team. Maybe we have some brainstorming on what we
kind of co-facilitate within
that would be great.
group discussion where we maybe move some of these tables together so that we're in a big, smaller circle?
Yeah, because it's, today is not many, right? So I think okay. Usually, what we want is that we want two groups. One is the Parkinson's patients, and then one is the caregiver. But I don't know how many caregiver in a room. So maybe you want to, maybe you can, yeah, something like that. I think this can close this, right? I think. Yeah, and then maybe you can moderate one, and now anyone that you want to moderate the caregiver, or just moderate yourself. Yeah. Okay. All right. Are you sure that you don't have any question about surgical? So actually, I don't even need it because it's in my brain. I'm just so sorry that I make it so nicely, a video. Oh, there's no answer for that. That's in my series.
I'm not sure I understand.
Oh, that's not related. So I don't touch, I touch it too. But actually, I just want to show you the picture, but I hope that the way I explain it to you, you can get a picture, right? You think it's good enough? Okay, all right, great. All right, thank you so much for coming today. Bye. And bye-bye from the virtual too. Okay, thank you. Bye-bye.